in general is important. The only way you find out more about it is by being educated about it, and there's a lot of myths about TB. So spreading awareness is breaking those myths and breaking that stigma so that people can be treated, effectively, and we can prevent, cases of TB, because obviously in general prevention is much better than cure.
Iemand wat TB het ook niks verkeerd gedoen. En iemand wat TB het is steeds iemand. Hy hoef nie om 'n hoekie geskuif te word nie. Hy is steeds 'n mens.
Well, there is life after TB after all. Well, the best way to eliminate this or to raise awareness about this is talk about it.
Whilst the world is currently grappling with the COVID-19 pandemic, we are reminded that tuberculosis or TB is one of the top 10 causes of death worldwide and the leading cause of death from a single infectious agent, just ranking above HIV and AIDS. Now, according to the 2019 Global TB Report, approximately 10 million people contracted TB in 2018. And in that year, there were 1.2 million TB deaths among HIV negative people and about 251,000 among HIV positive people. So TB continues to be the leading cause of death in South Africa. It is estimated that in 2018, over 300,000 became infected with TB, and of these, a total of 63,000 people died, 2/3 of whom were HIV positive. So March is TB Awareness Month, and the World TB Day is celebrated on the 24th. On this day, South Africa reported 554 confirmed cases of COVID-19, and today, March the 25th, that number has risen to 709 cases. Now, one of the many questions people are asking is, what is the possible impact of COVID-19 on TB and vice versa? Well, today we discuss TB and we'll help clear all of those questions. And to help us understand this topic better is a panel comprised of the Director for Drug-Sensitive TB from the National Department of Health, a pulmonologist from Helen Joseph Hospital, and joining us via Skype is 2 MDR TB survivors and someone else who has latent TB. Be part of the show by asking the panel some questions or simply just sharing your views with us. The number to call is Johannesburg 714-5861 or 5877. You can tweet us at SABC Health Talk or simply interact with our Facebook page, SABC Health Talk. Sit back, relax, and learn from this bumper show coming to you just after a short break. I'm Dr. Silla Mutaung, and this is Health Talk.
Individuals will not be allowed to leave their homes except under strictly controlled circumstances. All shops and businesses will be closed except for pharmacies, laboratories, banks, essential financial payment services. The nationwide lockdown is necessary to fundamentally disrupt the chain of transmission across society. I call on all of us, one and all, to play our part and our role as South Africans.
I'm Pumeza Tisile, I'm 26 years old, I'm from Khayelitsha, Cape Town.
Ek is Werner Geldenhuys, ek is 'n gesondheidsinspekteur, werk vir die stad Kaapstad, 33 jaar oud.
My name is Pat Bond, I'm a registered nurse by profession. I live in Somerset West.
So I went to the private doctor, the doctor checked the common diseases, diabetic, high blood pressure, even HIV, they all came back negative. And then he saw that there was really something wrong with me, which he gave me Panados just to get rid of the fever. And from there, he just said, no, go to the public clinic to get tested for TB because private doctors don't test for TB. So I went to do a chest x-ray, and from the chest x-ray, I remember him saying this, wow, this is bad, because at the chest x-ray, there were holes there. The chest is supposed to be black, but mine wasn't black, like dark black, it had spots there. So from there, he said, I had TB.
When I became ill in about the September of 2010, And initially I was diagnosed as having pneumonia, and I was put on antibiotic treatment, and I just didn't get any better. Eventually in the December, when I started with night sweats, a bell rang in my head and I realized I better go for more tests. So I went for another set of x-rays which showed probable TB, query pneumonia.
Skielik begin hoes en ek het begin bloedhoes en geskrik en geweet regtig wat aangaan nie en ek is ongevalle toe. Opgeneem, hulle het 'n paar toetse gedoen dadelik. Toe het hulle gesê maar dit kry niks op daai oomblik regtig verkeerd nie. Kan huis toe gaan, is dit weer gebeur omdat ek dadelik inkom. En toe 2 dae daarna, toe ek heel wat meer het ek begin bloedhoes. Groot geskrik, dadelik teruggegaan hospitaal toe. Toe in daai 2 dae se tyd toe die verslag van die een toets teruggekom. Toe is dit nog gediagnoseer met TB.
Initially the diagnosis was just TB, but within a week or so it came back as being multi-drug resistant TB, which was quite a shock to me.
So I was given normal TB drugs for about 3 weeks, like 3 tablets, and I took them, but then I wasn't getting any better from the drugs.
All right, it's a great pleasure then to introduce our guests for today. First up, Dr. Lindy Mvusi, who's Director for Drug-Sensitive TB from the National Department of Health. Welcome to Health Talk, Dr. Mvusi.
Thank you.
Well, and of course we have Dr. Mrumisi Mukansi, who's a pulmonologist and head of ICU based at Helen Joseph Hospital. Welcome to Health Talk, Dr.
Good morning to you and your listeners.
Right, and of course both of you know strangers to this show, and yeah, I'm grateful that you made time to come and educate or share your knowledge and expertise with our viewers. First, let's start with you, Dr. Mukansi. We're talking TB. I know everybody's focus is on coronavirus and COVID-19. Just so that we don't forget, what is TB?
TB is a disease of the body that mainly affects the lungs because of its way of entry.
Right.
And it's usually spread by droplets, which are aerosolized by coughing, sneezing, or even spitting.
Right.
And that's how it gets into people. So it affects mainly the lungs because of the entry point,
Right.
but it can affect any other part of the body.
All right. I suppose very relevant question would be that, you know, what you've just described now is what everybody's talking about in terms of COVID-19. What are then the differences between TB and COVID-19?
The problem in the main would be that the acuity of the problem. So if you have TB, it would usually be that you have had a longer duration of symptoms,
Right.
which are mainly night sweats. So you're drenched in sweat in the night when you wake up, you're coughing, you have fever, and perhaps a positive contact of TB as well, and maybe a negative travel history in the main. While when you have COVID, it's really more similar to most flu-like illnesses, that it's an acute problem
Yeah.
in the main, with really cough, maybe dry cough, and with fever and headaches and some sore throat and maybe fatigability as well of the body.
Yeah.
So it's really the acuity of the issues.
And again, the fact that obviously COVID caused by a virus and TB a bacterium. But obviously, how you know, I shared some figures, you know, in my introduction, mainly around, you know, the global picture, and came back a little bit into South Africa, but counting figures from 2018.
Yeah.
Do we kind of have a sense of the burden of TB in this country?
Well, yes, we do. And one thing, South Africa is still one of the countries that have a high burden of TB, and as indicated in the global report. In terms of the numbers, we are reporting around 265,000, which was in 2018. And but we know that the estimated numbers that we should be reporting is around 390,000.
Okay.
So there's still a huge gap in us trying to find people who have TB and are not aware that they have TB. Secondly, there's high mortality rates, especially in people who are HIV positive compared to those that are HIV negative. Now that's concerning, because even if you are HIV positive, you should still have good outcomes once you're treated for TB. But when we looked at it further, we found that most of the patients who are dying are those that are co-infected with HIV SAM, and the majority are not on ART. So we still need to ensure that TB patients who are HIV positive access ARTs.
So this is despite the fact that we have a large number of, patients who are HIV positive on ARTs. What you're suggesting is that those that are co-infected with TB may not actually be taking the ARTs.
Yes, some of them are actually tested during TB treatment or on diagnosing TB. So they do not access antiretroviral treatment on time. The other group are patients who are on ART, but then were lost to follow-up or stopped taking ARTs, and then they develop TB, and that's how then they are brought back onto the system. But I think the difficulty is convincing people to start early, because we still have those that are diagnosed and know their status, but not starting on ART.
We'll come back to those challenges. Let's just go back to the whole notion of transmission now. Firstly, how is TB transmitted? I know that you mentioned, airborne droplet spreads and so on, but let's just make it completely clear to our viewers, especially in terms of the differences in transmission between COVID and TB.
Yeah, with TB, we think that it's really droplets that are aerosolized by coughing, by sneezing, and by the spitting.
But then
it's transmitted
in the air.
Yeah, and then in the air.
Right.
And what we know as of now, as of COVID, is that it's probably droplets, which may catch up with you within 1 to 2 meters. So it's not yet known, and it's not yet believed that you can get it aerosolized.
Yeah.
And that is really the main difference, that the other one can be airborne and can be aerosolized to your thing.
Okay. So let's get back then to TB. Who gets TB?
In the main, TB, anyone can get TB, and it can be cross-cultural as well. However, there are a few risk factors that are glaring. It's those that are immunocompromised. So if ever you have especially HIV infection, and you have about 15 times likely chance of getting TB. And when those two are together, they speed up each other, so that you get HIV to AIDS and maybe TB to the whole body and causing more damage. The other thing, those that are diabetic and maybe any other of the immunosuppressive illnesses, which maybe we didn't go through each one of them. The other, it's a socio-economic problem, that people that are poor, undernourished, and live in conditions whereby there is overcrowding, and maybe no aeration and no ultraviolet light, because remember, ultraviolet light is good in killing the bugs. So if you stay in a house that is not necessarily well ventilated, and there is not necessarily ultraviolet light, and you're in contact, especially during darkness, like in the night, you sleep in an overcrowded place, then you're more likely to have TB in those instances. And maybe healthcare workers, because of our exposure to people, we also not short of a risk as well that we may get this thing exposed.
Okay, let's just come back to looking globally. I mean, obviously in this country at TB, the challenges. And I know that you started talking a little bit about contact tracing and so on, and I'd like you to comment on the whole SDGs, our targets. In fact, we have very specific targets to attain in 2020. How are we doing in that regard, and what are the challenges that we're facing generally?
The main targets for the SDGs and end TB strategy as well were including the UN high-level meeting targets, are that we need to reduce the incidence of TB as well as reducing the mortality. And the one for 2020 specifically was to reduce the catastrophic costs for TB patients and their families. Now, in terms of where we are with TB incidence, the incidence generally is reducing, it's coming down. But we have a gap in terms of the numbers that we're reporting, as I highlighted earlier, that we still need to find people out in the communities who have TB but do not know that they have TB. When you look at drug-resistant TB, we find a similar picture that the incidence is actually coming down, but it's also mirroring what's happening with the TB generally.
Okay.
When it comes to the mortality, I indicated it's quite high, and TB is still a leading cause of death in South Africa. So we need to do a lot to reduce TB deaths. And on the catastrophic costs for TB patients, which is related to poverty mainly, we are really not sure what our baseline is at this point, and we still need to determine that. We're planning to conduct a patient cost survey as recommended by WHO.
My apologies for interrupting you, but I'd like you to come back to that, during the course of this discussion when we start talking treatment and so on. For now, before we go on a break, let's take a caller. Leanne on the line from Johannesburg. Leanne, welcome.
Good day to you.
Hi, Leanne. Go ahead.
Yes, I would like to ask a question that's a multitude, actually.
Right.
We've got TB, is the death certificate of HIV in a basic sense, but with the coupling of this coronavirus, which is going to be the death sentence of people that stay in Sandton right up to Limpopo, down into wherever in this country, and in between the borders, because we still have movement. And people don't understand what lockdown means as yet.
Okay.
There is going to be several million people dying in this country if we don't realize what's happening.
All right. Okay, Leanne, thank you very much. I think, like you said, it's really a multi-pronged question, and we'll try and address all of those factors. I think the one was obviously the relationship between coronavirus or COVID-19 and TB, and the fact around movement of people from more affluent areas like Sandton to more rural areas and so on, and the impact that it'll have on our healthcare systems. We will try and address those, but for now, time for a quick break. When we come back, we'll try and address those questions and speak to some other people. Please stay with us.
An absolute decimation from the whole share index.
Stocks feeling an enormous amount of pain. I think a lot of people are very concerned.
We already expect the Reserve Bank to act aggressively.
Don't over-pressurize them. Leave the conversation to me and the governor of the South African Reserve Bank.
Meter taxi drivers, you find them a lot when you come out from their arrivals. They say business today particularly has been very bad, and they are very concerned.
Individuals will not be allowed to leave their homes except under strictly controlled circumstances. All shops and businesses will be closed except for pharmacies, laboratories, banks, essential financial payment services. The nationwide lockdown is necessary to fundamentally disrupt the chain of transmission across society. I call on all of us, one and all, to play our part and our role as South Africans.
Welcome back. We're talking TB with Dr. Murumisi Mukansi, who's a pulmonologist, and we're going to be joined later by Dr. Daleen von Delft, accompanied by her husband, Dr. Arnie von Delft, and they're joining us via Skype, but we'll connect with them just now. Dr. Mukansi, I just want us to start with, just the basic things again. We hear that there's different types of TB. There's latent TB versus active TB, and then the question of resistance. Can you perhaps just take us through all of these terms, please?
Latent TB, Dr. Mutaung, means that you are infected with the mycobacterium. However, you're not manifesting with disease or symptoms.
Yeah.
And the nice thing is that you may not be passing it to other people. You're not infectious.
Right.
So that's one thing.
And you don't require treatment.
And you may not require treatment because then we don't know that this thing, but you require a follow-up and maybe surveillance that you don't develop into disease.
Yeah.
Yeah. And then susceptible TB, mainly it's those that have susceptibility to especially two very vital components of the TB treatment. So that's rifampicin and isoniazid.
Yeah.
And then if you're resistant, that means you perhaps are resistant to one of those or two or even more. And then there's a few stages of resistance. One of them will be multi-drug resistant. That means at least resistant to rifampicin and isoniazid. And there is about a small percentage, 6% or so, of those resistance that are resistant to two other classes of medications that you can still use.
Yeah.
So if you add fluoroquinolones and add some intravenous injectable medication, then you are at XDR-TB, which means, yeah.
All right. Okay. So it's a spectrum, as it were. All right.
Spectrum.
Talk about that. I mean, we have via Skype, we joined by Dr. Darlene van Delft, who herself is a multi-drug resistant TB survivor. Dr. Darlene, are you with us?
Yes, hello. Thank you for having me.
Great stuff. Now, I believe that obviously you accompanied by your husband, or the other way around. The husband is accompanied by yourself. Just tell us a little bit about yourself and how you contracted TB in the first place.
Good. So 10 years ago, I was diagnosed with occupational MDR, or multi-drug resistant TB. I was admitted on Christmas Eve, isolation room in the hospital, and started on 7 different drugs. One of them was unfortunately, I started realizing these antibiotics had a lot of side effects. Ranges from nausea and vomiting and hair loss. Unfortunately, one of the irreversible side effects was unfortunately 8 weeks into my I started developing IPT. I was of course concerned about this because I gave my disability stethoscope, thus as a doctor. But my doctors told me that at this stage MDR had a grade of about 50%. So they said it's rather death than dead. So we have to continue with it. Luckily, with help of my husband, backup plan, new medication, and I was extremely lucky. I was the first world it was the first TV.
I'm afraid we're struggling a bit to hear you clearly, and I'm not sure why, because when we tested, we could hear each other a lot clearer. Let's see if perhaps if you just give it a short break, and we'll come back to you. Dr. Mukansi, you know, I think this illustrates also a point. We were talking earlier about who gets TB, the risk that healthcare workers are faced with in terms of, you know, contracting this from patients, and I think there's a direct correlation also around, you know, the COVID-19. Perhaps you might want to add a comment or two.
Yeah, my little comment about that is that healthcare workers, because of being in the forefront, they are exposed to this, and especially those that work in times when it's dark, there is no ultraviolet light in places that are not ventilated, they are more at risk, because one of the treatments in the days gone by of TB would have been ventilation, good ventilation, and good ultraviolet light exposure to the mycobacterium. So if you're in contact with them in overcrowded spaces, obviously our setup does have a lot of that. You may find that you're exposed to TB, so we all are exposed, and those that would be susceptible and maybe even under stress of work, they end up coming up with TB as well.
Yeah, I mean, she mentioned a concept there that, you know, it's occupational exposure, as it were.
That's it. That's
so in that instance, is it, you know, treated as a compensable kind of condition under, you know, the the old Workmen's Compensation Act.
It should be. It should be. Yeah.
Right. And so I know we'll come back to the issue of prevention and protection of healthcare workers and so on. But in your opinion, is there enough being done, or what can we do more to protect healthcare workers?
I think there's enough being done. It's mainly that there is exposure and there is people, and if we can decrease the time that we expose this thing, that will be fine. And maybe in screening for people that have TB, so that we know them early and treat them early and keep them away from healthcare workers in terms of us protecting ourselves. So when you go in there, you have a mask and maybe you're gloving, and you wash your hands when you go in, when you come out, and that way we would be safe.
And healthcare workers are quite familiar with these anyway. Let's see if we can reconnect with Dr. Darlene van Delft. Dr. Darlene, let's try again. Hopefully this time we can hear you clearer. And so just take us through what you went through at that time. When you realized that, you were infected, obviously, during the course of your duty. What did it mean to you?
It was a very difficult time. Can you hear me?
Yes, go ahead.
But luckily, my story has a good ending. I got access to a new drug called bedaquiline, and I managed to save my hearing, and I survived. I completed 19 months of treatment. I'm very happy that today in South Africa, all drug-resistant TB patients have access to bedaquiline, and the injectable therapy causing hearing loss is no longer in the regimens that is prescribed for drug-resistant TB patients.
Right. And if I may ask, what work are you doing now? Are you still, in the forefront, consulting patients, as it were?
Yes, so I'm currently created virtual care. I do much of this Skype interviews with patients and assist. And I'm also involved in TB Proof, where we try to raise awareness by sharing our stories, also trying to break down the stigma related to TB. And then we focus on advocacy and improve TB prevention.
All right, okay. Let's for a moment speak to your husband, Arno. So Arno, you contracted this as a result of direct exposure from your wife. Tell us how this happened.
Yeah, there's this rather poor joke in our family about my wife had TB, I still have mine. 2 months after Darlene was diagnosed, I became ill as well. And it's a complicated story, but the summarized version is that I had a TB infection. So as you explained previously to your guests, you can have a TB infection without having the disease. So I recovered without treatment. We could never prove that I had TB disease, but the blood markers showed that I had TB infection. And that means that I'm at increased risk of becoming sick with TB disease at any stage of my life. The risk is bigger in the first 2 years, but the risk remains lifelong. So that meant that every time that I cough, that I become sick, that I have a flu, we have to worry and wonder whether this cough is now also multi-drug resistant TB. It's particularly worrisome now because we're blessed with 2 young children, but also with colleagues. As healthcare workers, we work a lot with people that are vulnerable, that are already ill, that have suppressed immune systems. So you don't want a healthcare worker to be potentially spreading TB, never mind drug-resistant TB. And as you showed previously in your statistics, healthcare workers are at increased risk of not only TB, but also drug-resistant TB. The risk for drug-resistant TB is 6 times higher, and that makes sense if you think about it, because people with drug-resistant TB spend more time in healthcare facilities, so we are more exposed.
Well, perhaps just the last question. I mean, I put this question to your wife earlier to say, how did this mean to you? What did this mean to you? The fact that, you were now in this position where you contracted this TB and you're still living with it, as you said.
Yes, it's been very difficult. I really hate infection. I really hate fact I could put people at risk all the time. As a healthcare worker, I hate it doubly because we are trained to do something, and so far I haven't been able to do anything about this unwanted infection. In the first 2 years, I postponed all exams, I stopped working overtime, I never slept as much or looked after my health as much. I even shaved my hair, I had longer dreadlocks back then, all in an effort not to become sick. And I also tried a course of antibiotics, which we think might have helped to treat the infection, but after 1 month of treatment, my doctor told me either stop the treatment or stop walking, because the treatment started attacking my joints, particularly in my Achilles tendon, in my heel, so I couldn't walk anymore. And I was left with the choice that either continue treatment for 6 months and not able to walk at all, and not knowing whether the treatment would work. So we are calling on researchers to improve the types of TB treatment that are available, but also specifically for people like me that are infected with TB and want to be rid of it. The new WHO guidelines recommend that all people that are exposed to TB should be offered TB preventive treatment. In the past, that was only for children under 5 years of age and people living with HIV, but the new guidelines say all household contacts should be offered preventive treatment, and also high-risk groups, particularly groups like healthcare workers.
Very, very well put. Doctors Arno and Darlene van Delft, I want to thank you so much for your time and wish you all the best, and continue the good work. Thank you very much.
Thank you very much.
All right. So back to you here, Dr. Mokansi. I mean, we had earlier a caller from Johannesburg. I think when you analyzed, that question, it was multi-pronged and perhaps more a comment than a question. Perhaps you may want to just have a comment or two in terms of, what you were saying.
Yeah, my observation from the comment is that she's worried about what COVID-19 may do, which, of course, if we don't stick to the do's and don'ts that are really basic hygiene, what our mothers taught us when we were young, to wash our hands, to sneeze properly, to greet properly, we perhaps may suffer the consequences and spread it to many more people. But I think with the programs that are in place, we stand to save a lot of lives.
Yeah.
So she should not be worried. That's really the message.
Right. We had another person that we're supposed to connect with over the Skype, and this is Dr. Zolola Sifumba. If we can, if we're ready, we will cross over and speak to her, but apparently we're not. So going back to perhaps, this couple, it shows quite an interesting concept, where you have occupational exposure, where one person, gets exposed and contracts the disease, and then direct, transmission from one to the other in a home setup. How common is that?
It's not uncommon when you look at the fact that they are an intimate couple and they share the space. They share the space in the absence of ultraviolet light. It may be not necessarily any better ventilation with laminar flow in the house where they live. So it's something that you would not be surprised if it happens. And of course, as the deed is that the partner are not seem to have had just a TB infection, but not necessarily infectious. So he has had the exposure.
And the concept that one had multi-drug resistant TB, but in fact the one that contracts, has latent TB. Is the expectation that if you come into contact with somebody with MDR TB, you necessarily also are going to have MDR TB, or is it not necessarily the same?
You see, the latency of the Arno's TB doesn't mean he didn't get the same bug, but what it means is that his body fought it better and controlled it. So he's perhaps exposed to the same germ, even though we don't have any genetic material to say so, because if you look at the index case, it means she's the one who brought it home. And so it must be the same germ, except that his body fought it better. And then controlled it.
But I think in terms of talking about, multi-drug resistant TB and resistant TB, the most important aspect of all of our discussion is prevention.
That's it.
And that we're going to get to immediately after the break. For now, quick break. Please stay with us.
the wake of the coronavirus outbreak in the country, mass gatherings such as church services, weddings and funerals have been restricted.
Restrictions have been made. Now it's up to the people to actually observe those regulations.
So you have heard of the term social distancing. What does it mean and how do you practice it in your everyday life?
One thing we've realized and have seen was a sharp increase in takeaway orders, as well as the Uber Eats.
Social distancing doesn't mean that you've gotten off from work but you can go for golf and you can go to a party or you can go to a restaurant. Social distancing means that you distance yourself socially unless it's absolutely necessary.
The police and in the support of the SNDF, we are ready to make sure that these things we talk about of complete non-movement will be implemented and will be implemented accordingly.
Welcome back. We're talking tuberculosis or TB with our guest, Dr. Lindy Mvusi, Director of Drug-Sensitive TB from the National Department of Health, and Dr. Murumisi Mukanzi, a pulmonologist based at Helen Joseph Hospital. All right. So, gentleman and lady, we spoke earlier. We spoke to, that couple that we had earlier that, we were talking around, the whole of risk of transmission and so on. And I did say that, the important aspect of, if there's any one most important, aspect of our discussion today is that of prevention. Let's just go through the principles of prevention, perhaps in terms of, the department plans, as it were, or projects that are aimed at prevention.
Okay. In terms of prevention, our main focus is to prevent people coughing up the droplets which contain the Mycobacterium TB. And one of the ways of actually doing that is picking up those people who are actually coughing and have TB, treat them early. But also for those who are undiagnosed and not on treatment, to contain their droplets. That is where now we say if you are in an environment like a home, make sure that you have adequate ventilation, open windows, open doors to improve ventilation. And secondly, also the use of masks, the surgical masks, to prevent the spread of the germs.
Yeah.
And
that person actively, so who must wear a mask?
Okay. From the TB perspective, the people who must wear masks are those that are coughing.
Okay.
Because, for example, if you come to a clinic, for example, you might find that in winter especially people come in coughing because of flu or whatever conditions. So we need to make sure that those that are coughing are identified, they are provided with masks, but before they leave the facility, they must be, sputum must be collected for testing.
Okay.
So that we know if they have TB or not.
All right, we're going to come back to that. Obviously there's very interesting correlations between this, obviously, and COVID-19 that, we're dealing with now. But for now, we need to just connect up with Dr. Zolelwa, who is joining us via Skype. Welcome to Health Talk once again, Doctor.
Hello, hi. Thank you so much for having me on the show again.
Right, Dr. Zat. It's a great pleasure to have you. So we've introduced you as an MDR TB survivor, and you got this, or you exposed this, during the course of your duty as a young doctor. Tell us your story.
Hi, so yes, I was doing one of my clinical years at a medical school, which is UCT, and basically I woke up one morning with a lump on my neck. I got it investigated, and eventually it came out to be multi-drug resistant tuberculosis, which came as a huge shock to me because at the time I had no idea that I was part of a high-risk population, but actually as healthcare workers and students, we're actually up to 3 times at more risk of contracting the disease. And I definitely think I contracted the disease while on duty from some of the patients that I was taking care of. So yeah, diagnosis was a huge shock, and treatment was basically a nightmare. I took 21 pills every day, and I had to get an injection. So it was quite a painful time, quite a difficult time. I really wasn't sure that I was going to make it, and the stats at the time, weren't that great. But yeah, unfortunately, I do think I contracted it while I was on duty.
So you mentioned you were on treatment, taking 21 tablets a day, some injections. How long was that for?
So that was for 18 months. So quite a long period of time. Yeah.
Okay. So any lessons there? I mean, oftentimes as healthcare workers, we would, harp on this issue of, patients must adhere to treatment and so on. And having experienced it yourself, I'm sure you'd have a sense of the difficulty that patients go through.
Yeah, definitely. I mean, the thing of taking pills every day for 18 months that make you feel nauseous, that make you vomit, that make you have joint pains. I mean, we've all taken antibiotics before, and they're not fun. So basically, that's what it is for a total of 18 to 24 months sometimes.
Yeah. And I see that you're obviously looking very, very healthy currently. Tell us about, what you're doing currently and in terms of, advocacy work on TB.
So at the moment, I mean, a lot of things have shifted because of the COVID-19. Right. But I was to go, and I probably still will, when the Olympics come up, I will be a part of the torchbearer ceremony. Okay. Just there representing as a health advocate, particularly from South Africa, a health advocate that is a medical doctor, but has also experienced what it is to be a patient. Basically bringing knowledge and education to South Africa and to the world.
Right.
So that's just one of the things that I'm looking forward to that's coming up.
All right. So we're talking now, I'm about to speak to our guests here in studio about prevention. Your last few words on prevention to the public?
So I think education, because the only way we can prevent ourselves from falling ill from a disease is to know what the signs and symptoms are of the disease, and so we can know how to adequately protect ourselves from those who are infected, and which is basically similar to the time that we're in terms of coronavirus. The best means of prevention is to actually find out more about the illness, find out what your risks are of contracting the illness, and actually doing things to prevent the illness. So for TB, that's opening windows, that's making sure there's ventilation wherever you are. And then, with that, it's also similar with the coronavirus epidemic, with people coughing and being able to transmit the disease. So there are a lot of parallels between coronavirus and TB. But basically, the biggest form of prevention is educating yourself and making sure that you know what the signs and symptoms are, and that you know where to go if you are suspecting that you have it.
Okay, Dr. Zolela Sifumba, I want to thank you so much for your time and all of the best in the work that you do.
Thank you so much.
All right, back to our studio here. I mean, we're talking prevention. She mentioned a very interesting aspect of the cough. I mean, I remember earlier years we were talking about, there was something that we're promoting about the cough etiquette in TB, which is quite relevant to today. Your comments?
Extremely relevant today and in the future is that whatever we're learning now for the present pandemic, we should not forget it, because it's basic hygiene, I would call it, cough etiquette, and protect others that are around you. So it teaches us about humanity, that I must protect those that are around me from what I may or may not have. So
let's just remind our viewers a little bit about what this cough etiquette involves, Dr. Mpusi.
Okay. Basically what it involves is that when you cough, you can either use your elbow cough into the flex of your elbow to avoid spreading the droplets, or you can use a tissue, cover your mouth and nose when you're coughing or sneezing, and when you're done, you must remember to throw that tissue into a bin, and then also to wash your hands.
Just the last thing around prevention, obviously there's screening and contact tracing. which is also quite relevant to what's happening now with COVID-19, because, if you find one person that's tested positive, you have to find the immediate contacts, as it were. How are we doing in terms of, TB, finding those contacts?
Yes, and with TB, actually, it's key, because if you are diagnosed with TB, you probably have spread it, the infection, at least to your immediate contacts, mainly at home. So our focus is that we start with screening the people you are living with at home, and making sure that if they have TB, then tested positive for TB, then they are started on treatment. If they do not have symptoms, because they've been exposed, we then treat them for infection, as Anno was indicating earlier. And for the treatment of infection, we now have revised our guidelines for
I'll tell you what, let me not. Okay, I don't want to spoil it, because I know you want to share that with us, but it's time for a quick break. We're going to come back and talk treatment, but that after the break. Please stay with us.
Taking a look at how the youth consume news.
I prefer using social networks for information.
I happen to find reading news on my cell phone more convenient than reading news in newspapers.
I do follow various news sites there, and I get the links to the news articles that I read every single day.
I prefer using the night to watch to get the news because of its convenient.
Watch Media Monitor Sundays at 9 a.m.
Welcome back. We're talking TB, and we're now going to be talking about treatment of TB amidst all this pandemic that we're dealing with now of COVID-19. Dr. Mokansi, perhaps let's talk about the principles of treatment for TB.
I think the principles of TB treatment would be that the first thing is obviously the drugs, that we need to educate the patients to know that it's a long haul. It's not a week and done. It's not a month until the symptoms and signs are better, your appetite is back, your cough is subsided, your night sweats are gone, then you stop it. You need to carry on, because this TB can remain latent for a long time. And the minimum is really 6 months for susceptible people, and then you can go on longer, up to 2 years, as you see other people, depending on what treatment regimen you are. That's one. Two is also contact tracing as well, which is really important, because then you may even get it back from the other people that you have spread it to. So after treatment, we must treat the other people around you and prevent them from getting to spread it to everyone else. And maybe make sure the resources are there for people to be able to comply, and educate them as to the healthcare facilities that are really geared up to deal with the treatment of the tuberculosis, so that they know that's the place to go when you have MDR, XDR, and you will be given the perfect treatment and be followed up properly.
Yeah, and we've come a long way in terms of, the different drugs that treat TB, in terms of, the ones that were toxic, had very serious side effects, to what we have currently. Perhaps you want to just quickly comment on that.
I think in the main, what should really improve is the duration of treatment. If I were to have a word or two, that if science can develop something that would cure TB in a shorter duration than what we have. But from the old treatment, rifampicin and INH, they still remain the backbone of treating this disease, despite the side effects. And obviously, if you're allergic or you have liver failure from it, then you may want to use one of the newer medications. And
but in terms of improving adherence, I mean, the whole notion of the combination drugs,
Yes.
All right. I'll tell you what, before, let's take Gertrude on the line. Gertrude, welcome. Gertrude, are you there?
Yes, I'm there.
Hi, Gertrude. Please go ahead.
Yes, but can I speak my language, please?
Yeah, let's see whether we can, go ahead.
Okay. isiZulu. My question ukuthi ngeke diagnose for TB treatment and then I take the treatment for 7 months.
Yeah.
And then the question yami ukuthi is it a possibility ukuthi ingabuya back and then maybe we are back after how many months or years, and then I was tested negative. So my concern is it possible ukuthi ingabuya back futhi?
All right. Okay. Well, there's a question. Treated for TB for 7 months, is there a possibility that it may come back?
The answer is if it was susceptible TB, 6 months would be adequate. 7 months, it's even a bonus.
Yeah.
However, if it's not the susceptible TB, it may still be lurking around, and there is a chance that it can recur.
Yeah.
Or she could even get another infection at another stage, depending on whether she's a higher risk person or not, or even a risk.
So let's talk about, helping those that are on treatment to stay on treatment, to make it easy for them to continue treatment until they complete that course.
That is a challenge for most patients because of the duration. They need that constant support. We are now looking at adherence counseling, and for those that probably are at risk of stopping treatment, those would then be provided with intensive support where we'll have a community health worker who continues to support them. And other patients stop treatment because of side effects, and again, education, as it was indicated, about side effects and what to do when you develop them are part of the education and counseling of the patient at that time. Community health workers as well are trained on identifying some of the side effects and referring patients back to the clinics should they have some of the side effects that need urgent attention. So with all those interventions, we're hoping that will improve the treatment outcomes and completion rates for patients on treatment.
Okay. I suppose the question that comes in is the impact, of COVID-19. We know that we've had over 700 cases now already. Should the situation get worse, what would be the possible impact on, TB programs, for instance?
Well, we are hoping it will not disrupt services. For patients who will still be presenting to facilities, they will still be screened and tested. And for patients that are already on treatment, there are mechanisms for them to have their treatment either delivered at home or through other means, especially if they are co-infected, so that they are delivered together with their ARVs if they are on decentralized
So the main message is that continue the treatment that you're on.
Yeah.
All right. Well, thank you so much for your contribution. And for you folk at home, thank you so much. On a more personal note, I just wanted to share something with you that Health Talk has been a personal journey for me over the last 6.5 years or so, and it's time to say goodbye. I want to thank you a million times for allowing me into your living rooms, into your personal spaces. It's been an absolute pleasure and a treasure that I'll cherish for the rest of my life. And I want to thank you so much. But it's not all over yet. A new look Health Talk is coming your way in a week's time. Same time, same place. And my main message to you is that please do take care of yourself. Remember that your health is your best asset. It's the most important asset that you have. You need to take care of it. We may, I'm sure, meet sometime in the future. Our paths may cross. And until then, please do take care and goodbye.
Belts have for a long time been part of South Africa's fabric. And as the world evolves, so do they. But many are moving away from the traditional way of saving, such as cash payouts, burial societies, or buying groceries in bulk. After realizing the power of collective saving, entrepreneur Mututu Khoba created Uno Stokvel.
So when Mututu came up with the concept of Uno to say now, he wants to enhance people and understand that, instead of using money recklessly, why not come together and join and become members of Uno and start building an economy for our black people.
New age Stokvels like Uno are prioritizing building wealth for themselves while building businesses that can help the economy.
It's high time as black professionals, as Africans, that we take this Stokvel platform and we use it for business. Because we are saving, there's billions of money that are saved through Stokvels. But this time around, we want to take those billions and turn them around to build an economy, and I call it a parallel economy to the one that we are having.
Their method of saving and meeting has defied a long-standing tradition, opting to use digital tools. Instead of meeting regularly, they do so only once a year. But every month, they use a video calling app which allows all members to participate in real time from anywhere.
And what's nice about it is that it keeps track of who's owning, how far along are you, and it actually gives you reminders when you're following behind.
These 5 are part of a group of more than 40 other business owners and aspiring entrepreneurs. Each member contributes 840 rands a month over 12 months, or a one-off payment of about 10,000 rand. Together, they've purchased a tissue-making machine that will enable them to be equal shareholders in the business.
We needed to find a business that all of us work on. And we realized that if we can get a tissue machine, then we can come back and manufacture the tissues. And then each one of us can be a salesperson in selling the tissues. You see, so it's not a business that is going to come and we look for other people who are going to run it. No, the people within are going to be the sales agents. And as they sell the tissues, they also get in